Good evening, everyone. On behalf of CCI, it gives me great pleasure to introduce today's topic of discussion, which is COPD in hospital management to ICU care. I'm Dr. Pratibha Singhal from Mumbai, for those of you who don't know me, and I welcome you to this lovely session with a whole bunch of really dynamic pulmonologists from all over the country. We have with us Dr. Preeti Sharma from Chandigarh, Dr. Dhaval Prajapati from Karamsad, Dr. Abhishek Agarwal from Guwahati, and Dr. Anand Agarwal from Sonipat. So we will have the flow of this webinar is going to be two short talks. The first talk by Dr. Abhishek Agarwal on in-hospital management of COPD, followed by Dr. Preeti Sharma, who will talk to us on ICU management of COPD. And followed by that, we will have a panel discussion where we will dissect some of the common clinical problems and dilemmas that we encounter in our day-to-day practice. If you have any questions, please post them in the chat box and we will try and take as many as possible at the end of the panel. Over to Abhishek's talk, please.
Good evening, everyone. Myself, Dr. Abhishek Agarwal. At first, I could like to thank Dr. Pratibha Singhal ma'am for a kind introduction. I could also like to thank CCI for giving me this opportunity for this webinar. Today in this webinar, we will be discussing about COPD hospital management. There are many guidelines for COPD management. Basically, we follow goal guideline, but still management of the COPD patient in hospital patient depends on the institutional protocols with the local stores available. The care of in-house COPD patients involve role of a pulmonologist, which is very important. Emergency department, where the patient is segregated and decided whether to admit in ward or ICU, or to be sent home to be followed in OPD. Then, if the patient is shifted to ICU, critical care team plays the important role. Trained nursing staff to manage the patient, and respiratory therapists and physiotherapists are very crucial for the management of the COPD patient. Dietitian maintaining the nutritional health of the patient and also managing the comorbidities in the COPD patients are utmost important in hospital management. We will be discussing this COPD management in a hospital setting by two case scenario. In the first scenario, we have a patient, 64-year-old male, Mr. X, came to emergency department with complaint of shortness of breath on exertion, with fever, cough, with yellowish expectoration for 2 days. He is a non-COPD patient with mild severity, with FEV1 of 74% of predicted, on treatment with inhaled bronchodilator on SOS basis. When the patient was assessed in the emergency department, his on physical examination, his SpO2 was 97% at room air, with positive finding of wheezing and bilateral breath sound decreased. PFT1 was done where FEV was 65%, and his ABG was more or less normal, pH of 7.39, PCO2 45, and PO2 72. His X-ray shows bilateral hyperinflated lung, and blood markers in blood test. His TLC was mildly increased, 11,600. CRP was less than 10. Rest was normal. Sputum stain and culture shows the sputum stain for bacteria was positive, and ECG was normal. So the patient does not meet the criteria for admission and was advised to follow up in OPD with advised increased dose of beta-2 agonist and also added anticholinergic. And he was advised an antibiotics. So in this patient, we have seen the patient was discharged home for the emergency. Now we come in the second patient with a case scenario where we see 69-year-old Mr. Y came to emergency with complaint of shortness of breath, both at rest and on exertion, fever, cough with yellowish expectoration for 3 days. He then COPD, non-COPD patient with moderate severity, with FEV1 of 54% and regular treatment with inhaled bronchodilators. On examinations, the physical examination, significant finding was his SpO2 was 91% at room air, his respirator was 28 beats per minute, and heart rate was 110 per minute. And he was using his accessory muscle of respirations and wheezing and with bilateral basal cramps. ABC showed pH 7.36 with increased PCO to 52 and PO2 was low 48. His excess of bilateral loss or haziness, and the TLC counts was 13,000. And CRP was 40 and rest blood reports were normal. And the sputum stain shows positive for bacteria and ECG shows atrial fibrillation. This is the X-ray of this patient where we can see there is bilateral loss or haziness with hyperinflated lung. So whether patient need admission or not, we need to decide. So we will see the criteria for hospital admission of a COPD patient. If there is increase in symptoms of the COPD patient, or the patient has severe background of COPD or comorbidities, or we have patients with new physical signs like cyanosis, edema, or patient coming with failure of exhibition to respond the initial medical management, or patient coming with newly occurring cardiac failure or arrhythmias, older age patient, or patient have insufficient home support, or there is a diagnostic dilemma whether there is a COPD exhibition or some other complications. In hospital management, the main goal is to evaluate the severity of the patient, whether it's a life-threatening condition or not, to identify the cause of exacerbations, to provide control oxygenation, and to return the patient to the best previous condition. Now, how to assess the severity? In this case, for the assess the severity, we follow this chart, whether it's a mild, moderate, or severe. If the patient dyspnea score, the visual analog score is less than 5, or respiratory rate is less than 24, or heart rate is less than 95, with SpO2 more than 92%, room air or usual oxygen prescription, and or where the patient's oxygen decrease change is less than 3% change of the norm, and the CRP is less than 10, then the patient is severe are mild in category of severity. In severe moderate case, there we see the dyspnea score is more than 5, respiratory rate is are more than 24, heart rate is around 95, more than 95, and the saturation is less than 92% of the room air, or patient with oxygen if he's already on oxygen, or there is change of oxygen level more than 3% decrease, or their CRP is more than 10. Any three out of these five, the patient qualifies in the criteria of moderate. If the ABG is obtained, which shows hypoxemia where PO2 is less than 60, or there is hypercapnia with PO2 or PSO2 of more than 45, but there is no acidosis, pH is normal. They are categorized as moderate severe patient. In severe patient, the categories the patient have all the features of the moderate, with the ABG showing patient having respiratory acidosis, and the patients classified as severe. This help us to classify the patients and decide where to admit. And we also should to have to see the other differential diagnosis that patient may have heart failure, pneumonia, pulmonary embolism by doing appropriate testing and start treatment. Now, when the patient is admitted by the emergency department, we have to see whether the patient have respiratory failure or not. If they have respiratory failure, whether the patient have it's a life-threatening condition or not. If the patient is in the respiratory failure with life-threatening condition, patient needs to be directly shifted to the ICU critical care, where he has to be managed. If the patient have no respiratory failure, then his respiratory rate is less than 24, heartbeat is less than 95, there is no use of respiratory muscles, no change in mental status, and their hypoxia improve with supplementation of oxygen by venturi mask with FiO2 of 24 to 35% with no increase of PCO2, which we have seen in the typically in the first scenario of the patient. If the patient have respiratory failure with no life-threatening problem, their respiratory rate is more than 24, use of accessory muscles is there, but there is no mental change. And he maintained his hypoxia with FiO2 more than 35%, but there is hypercapnia, hypercarbia with PCO2 is increased from the baseline or elevated 50 to 60 millimeter of mercury. In case of acute respiratory failure with life-threatening condition, patient hypoxia does not improve with supplementary oxygen with FiO2 of more 40%, and they have mental status change, and the hypercapnia increases there is an increase in PCO2 for the baseline more than 60, and there is presence of acidosis. These people are classified as acute respiratory failure at life-threatening, and they need to be managed in critical care under critical care ICU. The cause of exacerbations in this usually we have to see what are the cause of exacerbations. Usually we have infection of the trachobronchial tree, which is most commonly viral. There may be pneumonia, cardiac failure, or arrhythmias, pulmonary embolism, pneumothorax, or the patient has been administered oxygen appropriately, or the patient is not taking his medications regularly, or there is poor nutritional status, or there may be some associated metabolic causes also, like patient may have CKD or CLD, which may lead to pulmonary edema, or some may have gastric bleeding. The how to manage a patient in ward. In ward, we have to manage the patient. Suppose this patient scenario, two patients shifted to ward with acute respiratory failure with no life-threatening conditions. The patients are prescribed bronchodilators, steroids, and antibiotics with respiratory support of oxygen if required, NIV or rehabilitation. Pulmonary rehabilitation is there, and adjuvant therapy. In bronchodilators, the short-acting inhaled bronchodilators, a beta-2 agonist with or without short-acting anticholinergics are the initial bronchodilator. Meter dose inhaler or nebulizer. No significant difference is there in the FEV1 with either of use of MDI or nebulizer. Nebulizer are easy for sick patient. Air driver nebulizer is preferable to oxygen driven one in acute exertions with a flow rate of more than 6 liters per minute and should be limited to 6 minutes. We should shift to long-acting bronchodilator while managing the exacerbation or start as soon as possible before the patient get discharged from hospital. Now, the role of steroids. Systemic steroids have definite role, which have shown to shorten the recovery time, improve the lung function, improve oxygenation, decrease risk of early relapse, treatment failure, and the length of hospital stay. A dose of 40 milligram of prednisolone per day for 5 days is recommended. Oral or injectable are both are equally effective. Nebulized budesonide is an alternative. Glucocorticoid may be less efficacious to treat acute COPD in patient with low level of blood eosinophils. Role of antibiotic guideline differ regarding the use of antibiotic in COPD. Trigger for acute exertion mostly are viral, maybe bacterial, fungal, air pollution, or temperature change. Antibiotics should be prescribed in the patient of acute exacerbations with three cardinal signs: increase in dyspnea, sputum volume, sputum purulence. Two of the cardinal symptoms, if increased purulence of sputum is one of them, should be prescribed antibiotic, or patient require mechanical ventilation like NIV or invasive ventilation. CRP or prolactin may be useful marker. Oxygen, for oxidation, the target of the SpO2 should be 88 to 92% with or without oxygen. Oxygen therapy, we should be low inspired O2 with Venturi mask or cannula. Sudden cessation of supplementary oxygen can cause life-threatening rebound hypoxia in the COPD patient. So we should be very careful while decreasing the oxygen. Reassess with blood gas measurement after 30 minutes is advised to see whether to increase FiO2 or not, or whether we need NIV use or not. If suppose the patient to improves with our treatment with steroids, nebulizer, steroid bronchodilator, or antibiotics with oxygen supplementation, then we can shift the patients, we can de-escalate the treatment. Suppose the patient is not improving, then he will read NIV. Now, what's the criteria of NIV? The patient having respiratory acidosis on repeat ABG, where the pH is between 7.25 to 7.35, PCO2 is more than 50 to 60. He has sign of severe dyspnea, suggestive of respiratory muscle fatigue, increased work of breathing, or use of accessory muscle, paradoxical motion of abdomen, retraction of the intercostal spaces. Or patient has persistent hypoxemia despite supplementary oxygen therapy, or his respiratory is still above 25. This patient needs to be started on NIV. With the patients on NIV response to the treatment, then we can think of de-escalating the treatment and shift the plan to discharge. But suppose some patient who do not respond to the treatment, they may need invasive ventilator and needs further critical care treatment. And now we see the indication of ICU, how when to shift the patient to ICU. Suppose the patient is not educated to respond to the initial therapy as we have given, and there is change in mental status, patient is confused, lethargic, coma, persistent or worsening hypoxemia, POT is less than 40, severe worsening respiratory acidosis, pH is less than 7.25 despite supplementary oxygen and NIV, and need for invasive ventilation, and the patient is hemodynamically unstable with need of vasopressor. Now, the water adjuvant therapy we can give, we have to monitor the fluid balance. Fluid overdose can maybe detrimental to the patient in a patient of COPD. We should be very cautious. Subcutaneous heparin for DVT and pulmonary embolism prophylaxis should be started. We should also treat associated comorbidity like heart failure, arrhythmias. Diuretics, when needed, clinically indicated, should be advised. Nutritional support should be given with concern with dietitian. Pulmonary rehabilitation should be started and with close monitoring of the patient condition. Now, if the patient has been stabilized, after stabilizing, so is being discharged from the ward or the patient is shifted from ICU back to the cabin and being discharged. For the discharge criteria, bronchodilators, patient should not have every more than 4 hour gap. The patient is able to eat and sleep without frequent awakening by dyspnea. Patient has clinically stable for last 12 to 24 hours. His arterial blood gas have been stable for last 12 to 24 hours. A patient or the home giver fully understands correct use of medications. The discharge criteria, while being discharged the patient, we should assess whether the patient has fully recovered and his all clinical and the laboratory markers are corrected. Check the maintenance therapy and understand patient attendance and the patient understands the maintenance therapy. We should reassess the inhaler techniques, ensure understanding of the withdrawal acute medications. uh, what may be the few symptoms patient may have due to withdrawal of steroids or antibiotic. We have to assess the need for continuing any oxygen therapy at home, provide management plan for comorbid conditions and follow up, and ensure follow up arrangement, early follow up within 4 weeks or late follow up after within 12 weeks as indicated. All clinical investigational abnormalities have been identified. While on follow up in the first visit, we should see all these parameters and also try to check whether the patient still needs oxygen or try to taper oxygen and standardize his nebulizer, his inhalers, or whether the patient is in need of long-term oxygen therapy, and also try to correct his comorbidities and check the status of the comorbidities. And from this discussion, we have a take-home message that we should try to rule out a differential diagnosis in acute exam COPD patient, try to find out the cause of acute exacerbations. A target SpO2 should be 88 to 92% with or without oxygen. Nebulize using air-driven nebulizer or MDI, both are preferred, both are equally effective. Optimize medical therapy and NIV use, and also we have to manage all the comorbidities to improve the quality of life of patient. Thank you. Okay, the ICU management of the patient of the COPD will be discussed in our next presentation by Dr. Preeti Sharma, ma'am. So I will hand over the next session to Dr. Preeti Sharma, ma'am. Thank you.
A very good evening, all of you. Thank you, Dr. Abhishek, for such an insightful talk and setting the stage so well. So, before we dive into what happens to these patients when they land up in ICU, I would like to thank CCI and Krishna sir for giving me this opportunity to be here on this platform, and also appreciate the dedication and commitment of CCI team to keep performing these webinars. So, let's begin. We all know COPD is a complex interplay of chronic airways inflammation, leading to airflow obstruction, the increased airway resistance, expiratory airflow limitation, which leads to the air trapping and gradually develops dynamic hyperinflation, leading to the development of the intrinsic PEEP as the alveolar pressures are more at the end of the expiration and leading to increased work of breathing. So whenever these patients have these exacerbations, which are triggered by various factors, which could be viral or bacterial or environmental, so these dynamics again worsen up. There is a worsening of expiratory flow limitation, dynamic hyperinflation, which has various deleterious effects in the form of cardiovascular. If we talk about it, is decreased RV preload, increase in the RV afterload. There's a tachypnea, dyspnea. The inspiratory muscles get tired, fatigued. There is impaired gas exchange as this progresses and leading to hypoxemia, hypercapnia with increased ventilatory drive, thereby requiring the ventilation. So the primary goals of treatment in these patients is to reduce the airway inflammation, reverse the bronchospasm, offload these respiratory muscles with the ventilation in the form of NIV or invasive, and to support the patient while we are awaiting improvement in the airway inflammation. So let's look at a case. 65 years old male who is a known COPD, reformed smoker, presented to ED with complaints of excessive cough with purulent expectoration, shortness of breath lasting for around 5 days. He's drowsy but arousable. He has tachycardia, tachypnea, desaturating to 88%. There is audible wheeze, use of accessory muscles of respiration. We get an ABG done in ED and see that the pH is decompensated. There is a respiratory acidosis with CO2 of 75, PO2s of 55. So we keep a provisional diagnosis of acute exacerbation of COPD, but remind you before doing this, always rule out an alternative diagnosis in such kind of patients, especially pneumonia, pulmonary embolism, heart failure, any kind of MI arrhythmias, pneumothorax, pleural effusion, which could be done simply with a bedside X-ray done, ECG. You have echo machines which can be assessed bedside and ultrasounds as well, along with the lab and biomarkers. So it is important that we know this patient has landed up in a severe exacerbation as per the Rome proposal, which was given by Goal 25. It is important to have a good management of these set of patients because these severe exacerbations are associated with significant morbidity and mortality around 25 to 30%. So we need to be careful about these set of patients. So what are the indications when we admit these patients to ICU? Severe dyspnea, which is not responding. Patient is confused, lethargic. There is a worsening hypoxemia with respiratory acidosis, pH less than 7.25, requiring oxygen and NIB, or there is a hemodynamic instability. So we start the treatments with, as usual, our inhaled bronchodilators. Systemic corticosteroids have shown to decrease the recovery time, decrease the length of hospital stay. They have to be given for about 5 days. Antibiotics, as per the local antibiogram, has to be given for 5 to 7 days. Again, they decrease the length of stay and the hospital stay. The supplemental oxygen, NIV, IMV has to be incorporated as per the needs of the patient, the nutritional support and the chest physiotherapy, which has to be laid emphasis on. So NIV is the first mode of ventilation for these patients, that is acute exacerbation of COPD patients. It has to be the first mode. It has been shown in various studies, various RCTs, meta-analysis, that it reduces the intubation rate and hospital stay along with mortality benefits in COPD patients with acute exacerbations. So what are the straightaway indications? The patient has severe dyspnea, increased work of breathing. So we give them NIV, the work of breathing reduces very nicely. Respiratory acidosis, where PCO2 levels are more than 45 ABG, shows a pH of less than 7.35 and persistent hypoxemia. NIV is a very good weaning facilitator. So we extubate these patients to NIV using NIV further as a weaning mode. So what are the contraindications to NIV when we cannot apply this? When the patient has a facial trauma or facial surgery has been done, the impaired mental status, the hemodynamic instability, there are arrhythmias happening, patient is uncooperative, there are excessive secretions, there is a high risk for aspiration, or there is an upper airway obstruction where we cannot apply the NIV. So NIV can be given with the short portable machines or the critical care ventilators or in between. So when we use this portable BiPAP machines, we have to use a single tubing, which is for inspiration as well as expiration. While for these critical care ventilators, we normally use the double limbs, which is different for inspiratory and expiratory limb. So the modes which we use in NIV are the BiPAP mode, which is commonly used for these set of patients because of hypercapnia, which could be spontaneous timed, or timed. So ST mode is the preferred mode because it gives you mandatory breaths even if the patient effort was not there, as we set up a backup rate. So choose an appropriate size, which is very, very important. When we do this, there's a small, medium, or large sizes of these masks. We need to see that the patient fit is well. It does not go below the chin or above to the eyes or forehead. So non-vented and vented masks, when to use them? Non-vented masks are used for the people, for the patients who are on the critical care ventilators because they have the double limb. So inspiration and expiratory limb is there. But when we are using in the portable BiPAP machines, we have to use the vented mask, which is very, very important because it is a commoner mistakes which are done in the ward or ICUs. So vented mask will allow the CO2 exhale out because we have a single limb and hence prevent rebreathing of CO2. Mask should be tight enough to just go away with 2 fingers, which could be between the straps and the patient's head. So these are the masks with the vent, and this is without vent, which are used in critical care ventilators. Now, how do we start the setting of NIV? Initial IPAP could be started at a pressure of around 8 to 10 with a goal of achieving a tidal volume of 6 to 8 ml per kg with a respiratory rate of less than 30 per minute. EPAP is set at 4 and then again titrated to achieve an adequate oxygenation. Minimum difference of pressure of 4 centimeter has to be kept between them. Maximum for IPAP, we can go up to 20. For EPAP, we can go up to 10. So patient may be allowed intermittent periods of this NIV for eating or expectoration of secretions. During such periods, oxygen supplementation can be administered through nasal cannula, but sister has to be advocated that they have to see, do not over oxygenate the patient, which again a mistake which is commonly done by the nursing staff. They just put the high flow oxygen and whatever we have done goes waste. So it is important to tell them about this. So monitoring during NIV is very, very important, even more important than a patient who is on ventilator. We have done all the settings. Here, NIV needs constant monitoring, early intensive monitoring, like for every 15 minutes in the first hour, every 30 minutes in the first 1 to 4 hour period. After 4 hours, it could be an hourly monitoring in the form of a chart, which we can apply in the files with the recording of pulse rate, respiratory rate, blood pressures, SpO2 levels, the ABG reports, and then the NIV settings adjusted according to these parameters. So how do we predict that our NIV is a success? If the patch score is less, patient is cooperating well, intact dentation is there, there are no air leaks, permissible air leaks are there, and there is a moderate to severe hypercarbia. So these are the patients who will improve with NIV. But if the severity of illness is very high, there's a pneumonia, copious secretions, patient is edentulous, NIV is likely to fail. So we assess that we have put the patient on NIV, the patient has bradycardia, hypotension, patient is going into fatigue, inability to clear secretions, and not tolerating NIV well. And we have already reached a peak airway pressure of 20 and EPAP of 10. Then this is the time when we should start thinking about intubating this patient. So there is a score, HACOR score, which can predict the risk of NIV failure, which measures heart rate, acidosis, consciousness, oxygenation, respiratory rate. All these parameters are given different scores, and then we calculate the total score. Score of less than or equal to 5 denotes a low risk of NIV failure, while if there is a score of more than 5 at 1 hour of NIV usage, then it denotes that there is almost an 80% risk of NIV failure. So how to wean these patients on NIV? Once the patient's clinical condition is stabilized, their oxygenation is good, PF ratio has improved, PCO2 levels have come near normal, the pressure support can be reduced in steps of 2 centimeters of water every 2 hours, maintaining the oxygenation levels, targeting SpO2 of more than 88%. And also the PEEP can be reduced in steps of 1 centimeter every 2 hours. So if any time during this down titration, we feel that the above parameter like our oxygenation is not met or CO2 levels are still high, then we can step up the settings again. So this reduction has to be done till the pressure support of 7 centimeters of water is reached and a PEEP of less than 5 is reached. So once the patient is comfortable on these least settings, we give them off hours of NIV about 4 to 6 hours with FiO2 adjusted around 88 to 92%. So weaning from NIV, again, after we have given them this space, now what we do is we keep a 1 hour off NIV every 3 hours, then we do it as 2 hour off every 3 hours, 3 hours off every 3 hours. Once we have increased these timings, then we give them NIV during the night. So it should be documented in your medical and nursing records. Now, what happens when this patient has further deteriorated in spite on NIV? The GCS has deteriorated, pH has decompensated more, CO2 levels have gone up to 90. So what to do next is to intubate this patient. So what are the indications for invasive mechanical ventilation? NIV failure is the first one because we have tried NIV. There is diminished conscious level. There is an aspiration, persistent vomiting. Patient is unable to remove the respiratory secretions, and severe hemodynamic instability is the commonest indication. Again, severe arrhythmias anytime happening on NIV has to be shifted to invasive mechanical ventilation. So what are the things which we should keep in mind while intubating these patients? Because they rapidly desaturate, it is important that we pre-oxygenate them with BiPAP or NIV. Volume status is very important. They have to be pre-filled because positive pressure ventilation along with DHI will lead to further hemodynamic compromise and patient can go into a shock state. So rapid sequence intubation should be done with the agents which are more hemodynamically stable, like ketamine, etomidate could be done. We should always be prepared for a difficult airway and keep all our things ready by the bedside, like bougie. And if the shock is still worsening so much, you should always disconnect the ventilator and manually squeeze the thoracic cage, which will lower the intrathoracic pressure. And also, hemodynamically, the patient will be better. So what are the settings we do on the ventilator while we have intubated the patient and put them on the modes? What mode to be used? Again, familiar mode should be used, which you know very well. Most of the times when we initially put them, we have to put them on an assist controlled ventilation, which could be either a volume control or a pressure control. A tidal volume of around 6 to 8 mLs per kg, respiratory rate 12 to 14 per minute. Increase IE ratio from 1:3 to, you can go up to 1:5. A high flow rate of 80 to 100 liters per minute should be set, keeping in mind that peak PIP pressure should be less than 40 and PLAT should always be less than 30 to prevent barotrauma to these patients. Another important highlight is a maintenance of a permissive hypercapnia. Never aim at drastically reducing the CO2 levels in these patients because they already have a chronic compensation with bicarb levels. So once we drastically reduce the CO2, there will be metabolic alkalosis, which will further lead to many problems like leading to increased ionized calcium, which can lead to the arrhythmias happening in the patient. Then patient will have more work of breathing. So it is important that we do not drastically reduce these CO2 levels. We need to adjust the triggers, the pressure trigger to 1 to 2 centimeters of water, while flow triggers to 2 liters per minute, which will help us in the preventing the patient ventilator desynchrony. PEEP setting can be at 5 centimeters of water. And low levels of PEEP are important. We have to keep this level of PEEP to improve the synchrony by offsetting the auto PEEP in COPD settings. So how can we know that the patient is generating an auto PEEP? When we look at these flow time curves, we see that the expiratory limb does not come to the baseline. Also in the ventilator graphics. When we see this, we know that the patient is generating an auto PEEP, which can lead to the patient ventilator desynchrony and has to be taken care of. How can we do this? We have to prolong the expiratory time, need to have a high inspiratory flow rate, need to give some intrinsic PEEP to adjust that, and the trigger sensitivity. After we have done all this, still we are not able to do this, we'll have an sedate the patient. Maybe if some required, we can also give a neuromuscular blocker to this patient. So aggressive policy towards weaning has to be done because otherwise these patients carry worse prognosis if they are prolonged ventilated. Auto PEEP can make things difficult for us, so we need to recognize it early and take care of it. Other factors like the things that increase the resistance, like the size of the ET tube is very important. It should be big. The secretions, kinking of the tube or any kind of HME circuit, which is increasing the resistance has to be taken care of. So weaning can be done with a mode of like pressure support mode, and extubation to NIV is a very good alternative in the patients who are failing the SBT trials. So once the patient is ready for weaning or not, we can assess this with a readiness criteria, which could be a clinical criteria, ventilatory parameters, the pulmonary reserve of the patient has good conscious level, hemodynamic is stable, ABGs are good, compliance is good, the fluid balance is okay, electrolytes are normal. So these patients have to be, we put them and see the RSBI, which is less than 105, and thereby we start the weaning process by communicating to the patient as well as to the nurse and give them the SBT trials after a spontaneous awakening trials. Now, what are the modes which to be used for weaning? Pressure support mode is the commonest one which we use. We can also use the TPS trials also. Other modes like newer modes, ASV, proportional assist ventilation or NAVA are used to prevent patient ventilator desynchrony well. And extubation to NIV is the commonest mode to wean these patients. So pressure support should be adequate enough to generate a good tidal volume. There should be a flow which is high set. Flow trigger is more important here because it has high sensitivity and will prevent any auto triggering. The rise time has to be a steep slope and a PEEP of around 5, which is said. So once we start putting them on the pressure support which is higher, then we gradually reduce this pressure support as we did for NIV. After the patient is tolerated the SBT trial for around 2 hours, so that is an SBT success with the clinical parameters, we assess them for extubation readiness, which is that patient has a good cough reflex, less of secretions, and then we extubate this patient and further manage them. So the challenges in weaning these patients is because of the dynamic hyperinflation, auto PEEP, the respiratory muscle weakness, which has to be taken care of. So do not give them more of paralytic agents because steroids can also cause weakness. We have to take care of these. The electrolyte balance has to be taken care of, and the psychological factors, whenever needed, they have to be given some anxiolytics. So what is the role of extracorporeal carbon dioxide removal? So when the patient has failed all the methods, we are not able to reduce the CO2 levels, the patient has a difficult weaning, NIV failure has happened, what we need to do is we can do this extracorporeal carbon dioxide removal, which reduces the PCO2 levels, enables lung protective ventilation, and also can avoid intubation. So it is a pumpless arteriovenous system or a pump-driven venovenous system like the Prisma lung device. And again, there is a protocol for gradually taking it off. So what are the key elements for the discharge? We need to check for the discharge readiness. We need to guide them about the medications they are to be given, educate them about their inhaler or nebulizer techniques, the home oxygen therapy, and refer them for pulmonary rehabilitation and the timely follow-up, which is very, very important. So goal 25 give us this discharge criteria, which could be early follow-up or a late follow-up. Early follow-up is from 1 to 4 weeks and latest from 12 to 16 weeks. At early follow-up, we again reassess them for a long-term oxygen therapy. We also look at their status of comorbidities and document the symptoms. So we need to check for all these things. And then we reassess these patients again at 12 weeks. When we see that whether these symptoms have returned to their baseline or not, we document the spirometry and the FEV1 volumes, everything. And then we again accordingly give the treatment to these patients. So the take-home messages are overall goal of the treatment is to provide the adequate gas exchange while minimizing hyperinflation, aggressive therapy to reduce the airway inflammation and bronchoconstriction. The primary cause is to be treated. NIV has to be the first mode of the treatment to be tried in these patients, while invasive ventilation is reserved for life-threatening respiratory failure. Ventilatory graphics have to be looked upon again and again for early diagnosis and management of patient's condition. And mechanical ventilation should be adjusted to pH and not to CO2. Do not drastically reduce the CO2 levels. Weaning from mechanical ventilation is difficult, but factors which could be corrected should be looked for and corrected. Early use of NIV may hasten the whole process of weaning. So, thank you so much for your kind attention. And now I will hand over to Dr. Pratibha for the detailed panel discussion. Thank you.
Thank you, Dr. Abhishek and Dr. Preeti, for that detailed discussion on hospital management of COPD and ICU management of COPD. A lot of practical tips, but we're going to move on further with a more detailed panel discussion. And some questions may be a revision, but they are important questions, so it's good that we discuss them again. So starting with Dr. Dhaval, you have a patient who comes to you in your clinic. You know he's an old patient of yours of COPD with recent acute symptoms. When would you label it an acute exacerbation of COPD and advise admission?
Okay. Good evening, everyone. So Dr. Agarwal has already mentioned about what is the exacerbation. Like whenever the patient is having increase in the dyspnea, baseline dyspnea, then the development of the cough, or maybe sputum production in the either in the prurulence or maybe in the frequency of the cough or sputum has been increased, and it is recently within 14 days and associated with the tachycardia or tachypnea. And there are some inflammatory, systemic or local inflammatory changes maybe we can observe because of the either infection or maybe pollution or maybe because of any trigger factor to the airways. So whenever there is a worsening of the symptoms, we can say patient is in exacerbation. And as already Dr. Agarwal has mentioned about the exacerbation, maybe mild, moderate, or severe. So based on that, we can always consider about the admission. Particularly, we can check about when the patient is having severe exacerbation, right? Based on the VAS score or respiratory rate, SpO2, heart rate. We can check about some laboratory test, ABG. So based on that, we can always think about which need to be admitted in the ward or in the ICU. And particularly when the patient is having severe exacerbation with the symptoms, or maybe having patient a worsening of the baseline symptoms with the progressive deterioration of the dyspnea, cough, or maybe development of the new or worsening signs and symptoms like altered mental status, like confusion or drowsiness, the hypoxia, like a PO2 level less than 50 or SpO2 level less than 88, hypercapnia, like PCO2 more than 45 with the development of the respiratory acidosis. Our patient may be having hemodynamical instability with the hypotension or arrhythmia. Our patient may be not able to maintain his routine activity with the routine investigation, routine treatment what he was taking. or whenever you see some comorbidities also having patient and it triggering or maybe deteriorating or decompensating because of the CO2 exacerbation, or whenever there is a diagnostic uncertainty because of the some mimicking diseases like pneumonia or cardiac diseases, or maybe like pulmonary embolism, or we can say pneumothorax or something. So whenever there is a mimicking COPD exacerbation, we can always think about the admission of the patient.
So in short, Dr. Dhaval, basically what we are understanding is that mild exacerbations can be managed on OPD basis. Moderate exacerbations are something that you need to look out for. And on a case-to-case basis, you will decide admission. Looking at some of the things that you said, maybe affecting activities, lack of home care, lack of being able to have support at home, where they can come to the hospital immediately. Of course, severe exacerbations are going to admit the patient immediately, right?
Yes,
am I right?
yes, yeah.
So moving on, Dr. Anand, you've decided that you need to admit your patient. How do you decide where to admit your patients, in the ward or in the ICU? I know we've already covered that, but again, to recapitulate it for the audience.
Yeah, definitely. Very good evening. So it has been covered, but there are practical issues which always left out that we have to discuss, because the question always raised whether we have to admit the patient to ward or ICU. There is another thing between, that is called HDU, high dependency unit. That could also be addressed, because at different setups, this HDU has also been there. That could also be used. So when we talk about the criteria of the hospital admission, then say practically, if we see the patient, those who can't be treated at OPD level or can't be managed at domiciliary level, that could be admitted immediately to the wards. Generally, the patients having respiratory distress and having the saturation that increased, or we can say is not more dynamically stable, or having some comorbidities even. Like if we feel that in a OPD, we found that there's some infectious condition, like pneumonia is there, or the patient developed hypertension or the diabetes, or such condition which can worsen the COPD, that is the indications to admit them in a ward, certainly. But if we go beyond it, as we do the workup and find out, so the other investigations like ABG or the VGA will say the pH is less, it is less than 3.5, also mentioned by Dr. Abhishek. PCO2, if it is more than 45, or the PO2 that got decreased, in that circumstance, we can think that whether we have to admit that patient in ICU or HDU. Because there are two things. When we admit the patient in ICU, there is a cost which get increased exponentially. So there is a middle way. We can admit such patients in HDU if there is a PCO2 that is not very high, or like more than 60 or 70, or it is less than it, or we can manage them on NIV. Then we can admit them in HDU, because monitoring is limited and it is not extensively monitored by the healthcare providers. So in that circumstance, we can admit them in HDU, though if patient need any, we feel that there is a worsening later, then we can shift them in ICU. If mechanical ventilator is required, like intubation, so dynamically you get destabilized, or there is some other thing like consciousness or the Glasgow Coma scan if we measured and it is less than 10, then we can say we have to shift them in a ICU monitoring, for the ICU monitoring, and we found will be comfortable, I think. So there are different aspects that could be chosen by the practitioner according to their setup.
Correct. So that's a good point that you brought forward about HDU setup when available in patients who are not requiring invasive mechanical ventilation, or who are not in, so the criteria that you mentioned, you could manage them in the HDU as well. So something practical is, very often COPD patients already have a baseline lower oxygen level. Their saturation is usually lower than normal patients, and we are acceptable of that, right? We don't want them to be super maintaining their oxygen level and blunting their respiratory drive. So just a little pointer, if their oxygen SpO2 drops by more than 4% of their baseline, that is something that would drive an hospital admission. And of course, if they have type 2 respiratory failure, you would put them into a HDU or a ICU setup. Coming to Dr. Abhishek, I know you did mention in your talk about viral infections being common, but what other organisms are common in COPD exacerbations which causing infection and exacerbation? Would you like to enlighten us on that?
Ma'am, as we have seen in our practice that most commonly it is a viral which causes the acute exacerbations. Most common is the rhinovirus, followed by parainfluenza, influenza, metapneumovirus. And in that case, we can found a sputum eosinophilia also, which may be a quick marker to get diagnosis. Then we have bacterial Streptococcus pneumoniae, then Haemophilus influenzae. But in our clinical settings, if we go the current scenario in our settings, Acinetobacter is the quite common, followed by Klebsiella pneumoniae. These two are common now in our hospital setup, which we are getting. But in literature, we get usually Haemophilus influenzae and this one, Streptococcus pneumoniae. Among now, fungus also is nowadays, we are getting a lot of fungal acute exacerbation case also, which may be due to patients not using inhaler or their nebulizer not doing rinsing their mouth after doing the inhaler. Maybe one of the cause, maybe not maintaining the oral hygiene, where Candida albicans has been seen now. Aspergillus is also being seen commonly. Atypical bacterial infection is also there, but we have no culture support for that to support.
Yeah. So viral followed by some bacterial like Streptococcus, Staphylococcus. You have H. influenza, Klebsiella. The other infections, Pseudomonas can also be colonized in COPD patients. Acinetobacter, fungal infections. We usually see in patients who've received recent antibiotics or other comorbidities, or patients who've had repeated admissions in the recent past, or have had, patients who live in healthcare facilities chronically and then who come to hospital for admission. Candida infection, yes, you can see because of inadequate, because of oropharyngeal candidiasis. Yes. So moving on, Dr. Preeti, based on this, what is your initial antibiotic therapy in COPD patients? Is it different from what you would treat for a community-acquired pneumonia or an LRTI? And again, would it be different for a ward admission versus an ICU admission?
Yes, Dr. Abhishek said most of them are exacerbations which are caused by the viral infections, but some of them are also caused because of the bacterial infections, which we are covering as H. influenza or Streptococcus pneumoniae, Moraxella. These are the organisms causing the COPD exacerbations in very common, almost about 60% of the cases, while atypical organisms, almost around 10% of the cases, they contribute to COPD exacerbations. So here, when we see that, as described by Dr. Abhishek in the talk, that sputum purulence, increase in sputum, as well as there is a severe dyspnea. So these are the patients, even in the ward settings, they would require an antibiotic, short course of antibiotic for around 5 days, wherein we can use our amoxicillin, clavulanic acid, or doxycycline, which will cover all these regular organisms in the ward. But if we are thinking about the severe exacerbations where the patient has landed up in ICU, we need to give a cover for anti-pseudomonal also. That is, the patient is frequent exacerbator. He has a very severe airflow limitations. The patient has a past history of antibiotic use. There could be concomitant bronchiectasis, or all of these things to be kept in mind while the previous hospitalization or any previous antibiotic use. So all these factors will qualify to give the patient an anti-pseudomonal penicillin, or with a combination of aminoglycosides. They have to be given for these set of patients. So we can divide them accordingly. As per the local antibiogram, also it affects how do we give our antibiotics, how is the flora of our ICUs and everything. And as the patient decompensates, or we find that more of the sputum cultures come over, and then we can prescribe the antibiotics according to the culture sensitivity reports also.
So you'll also add a atypical cover.
Yeah, and when we talk about difference from community-acquired pneumonia, of course, there we have to give a combination of the therapy with macrolides. Here we can do with a single therapy also while we are treating these exacerbations, which are mild to moderate. Only when we are thinking on the lines of atypical, we can add up macrolides, but it is not a necessity as we has to give it in a CAP patient.
Great. So coming back to Dr. Dhaval, COPD patients also have other comorbidities, and how often do you suspect that it's a cardiac cause that is driving your COPD admission and not a COPD exacerbation? And what cardiac causes would you anticipate?
Okay. So uh, I'm just adding the last question as well. Nowadays, the MRSA coverage we also think about when the patient is having like higher prevalence rate in the ICU. Okay, so come to my question regarding the comorbidities. So yes, the respiratory and the cardiac is going hand in hand because of the it's a dependent on each one, because sometimes because of the COPD exacerbation there is an increase in the pulmonary pressure and there is a back pressure to the right heart, as well as the hypoxia, hypercapnia, all leads to the and the ultimately the systemic inflammation all leads to the exacerbation or decompensation of the cardiac conditions like heart failure particularly, right? So whenever the patient present with the COPD exacerbation, we always think about the moderately high. We have to think about the is there any cardiac comorbidity or cardiac components decompensated is there or not. So like heart failure particularly. So whether it is systolic heart failure or diastolic heart failure, like as I mentioned, whenever there is a COPD patient is having exacerbation, again there is an increase in the pulmonary pressure with the systemic inflammation. The patient can go into decompensated acute heart failure, and vice versa. Acute heart failure can again lead to pulmonary edema and the development of the respiratory symptoms. The another thing is acute coronary syndrome, where patient is because the hypoxia during the exacerbation, patient oxygen demand is increasing, and there is a decompensation with the acute coronary syndrome. The another is cardiac arrhythmia. Patient can present with the palpitation, dyspnea, cough sometimes, and again, because of this hypoxia, hypercarbia, the inflammation, the AF can precipitate it. And because of the patient having AF, there is a low cardiac output and ultimately leads to the respiratory symptoms. The another rare, but like CORP is one other disease which can present with the respiratory symptoms with the pedal edema and the right heart failure. The sometimes we can see the pericardial effusion or tamponade that also can present with the respiratory symptoms, and like hypertensive emergency is also present with the respiratory symptom with pulmonary edema. But we can always clinically as well as the laboratory wise, we can always rule out the cardiac decompensation like new beginning of or new worsening chest pain, or patient may have sudden drastic change in the blood pressure or heart rate, or you can see the arrhythmia, development of the peripheral edema because on raised JVP, right heart failure, or whenever the patient having disproportionate dyspnea as compared with the pulmonary function test, then also we can think about the cardiac presentation. And always, yes, ECG, echo, as well as the cardiac biomarkers are always helpful for the diagnosis of the cardiac condition. And whenever there is we treat the patient, but patient is not improving with our routine bronchodilators, steroids, then we can always think about the other diagnostic dilemma with the cardiac component.
Okay. So just one point that I wanted to bring to everybody's attention is that we are talking about MRSA cover and Acinetobacter cover. At this point, we are still talking about community infections. So if you are having a patient in whom you're thinking of a secondary hospital infection in a COPD exacerbation, sure, you would like to cover these higher organisms, but I don't think adding MRSA or Acinetobacter cover when a patient is coming in from the community would be ideal unless you're suspecting that there is a secondary hospital acquired bug as well. So
one point where we should try to avoid fluoroquinolones use in our settings, ma'am, because in India we are already a high burden TB country with a lot of MBR patients. So fluoroquinolones as a first line should be avoided in the patient without culture report.
Correct.
In our setting.
Correct. So, Dr. Anand, would you like to add something to what Dhaval has already said, that if you have a patient of COPD exacerbation, sometimes the symptoms are very similar: breathlessness, cough, difficulty in lying down. How will you differentiate it with concomitant heart failure or a right heart failure occurring due to cor pulmonale?
Yeah,
any pointers?
It is very tricky actually, because there's a very common coexistence and common presentation when the patient admitted in ICUs. Generally, we think that the patient may have admitted due to the COPD exacerbation, but many times there may be some comorbidity that may worsen the condition, even like CHF. As Dr. Dhaval told, related to the symptoms and the differential diagnosis, when we think that the chances of this CHF may be high, the patients clinically presented in that manner, like the patients have history of orthopnea, or somehow there are some radiological picture which gives the idea about the CHF, like curly V lines, or there are some claustropenic angle obliteration bilaterally, maybe some pleural effusions or in the form of pedal edema. And we think that the patient may have some signs of CHF. Even in ICU, we can assess the patient through the focus point of care USG. That will give the very good idea about the pulmonary edema that may be due to the CHF. So if B lines are there and it is more than 3 to 5 per field, then we can say that the patient may have the chances of pulmonary edema. That is a non-invasive method and easily can be assessed the patient about the CHF. Along with that, the clinical features make the diagnosis. ECG is no doubt a very important this test to be assess the CHF condition. Besides this, some biomarkers could be said, like BNP and pro-BNP or anti-BNP, that will give the insight whether the patient has some features of CHF or not. So the cutoff value will be good enough if it is more than 100 for the pro-BNP and more than 300 for anti-BNP, then we can say the patient may have features of CHF. Along with that, if we talk about the focus, as I'm much interested in the USG in the ICUs, because I'm used to do that, EPSS sign is very, very important sign. As we do the cardiac this USG, then E point septal separation sign, if it is more than 7 mm, then it is very, very significant. If it is present in the patient, then we can say that patient is also in a condition of CHF along with the COPD. The COPD we can diagnose definitely by the ABG, and other parameters of the CHF could be diagnosed by all these parameters and diagnostic tools.
Thank you, Dr. Anand. Very good clinical pointers that you have added that can help us bedside. Another thing clinically which we see often is that usually these patients don't have a lot of wheezing, unlike our asthma exacerbations. So if you have a COPD patient who is wheezing quite a bit, always think of whether there is a cardiac coexistent pathology as well. Just a small clue in my clinical experience. So moving on, Abhishek, would you do an EBG routinely for all your COPD admissions?
For a all patient, we don't routinely recommend, but the patient who are in the mild category is stable, we don't recommend. But the patient whom we are suspecting hypoxia, severe hypoxia or hypercapnia, in that category of patients, we recommend ABG to assess the need, where to admit the patients, the need of NIV, and how to give control oxygen to that patients, ma'am. Because often patient, when given oxygen, may end up with hypercapnia and leads to decreased maintenance, may end up in ICU also, ma'am. For that, routinely it is not recommended, but in moderate to severe case, we have to see and have a ABG at baseline.
Correct. Sometimes you see that a patient's baseline CO2 is not very high, it's 45, 48. And then after they receive in the, over enthusiastic doctor in the ER gives the high flow O2, and then you have a carbon dioxide. Suddenly, by the time the patient is in the ward, it goes to 80. So it's important sometimes when you are not sure, when it's not an old patient, you don't know the baseline CO2, it may be worthwhile because it will drive your management of oxygen versus NIV versus where you are admitting the patient. Very well. So coming to Preeti, bronchodilators in COPD patients, any preferences, any precautions?
Yeah, as per the guidelines, the short-acting beta-2 agonists with or without our short-acting muscarinic antagonists have been the preferred agents for giving the bronchodilation, especially in the patients who are presented to us with the severe exacerbations, where we can give this repeatedly over the period of time. The SAMAS can be given for every shot can be given within 20 minutes up to 3 times, and then up to 4-hour period, whatever the short duration is. So the studies say that the combination does not do any better than the single agent as well. So even if we give SAMAS only for these period, it would do much better than giving the combinations. So the side effect profile of these agents is not, most of the times you're giving it such number of times that it can result in tremors. Sometimes the restlessness is there, anxiety happens. There could be sinus tachycardia with these short-acting beta-2 agonists, as well as if we talk about the muscarinic antagonists, there could be the problem with urinary retention, but it is seen very less commonly in the patient and it is not seen very frequently, even if we give it at such frequent times. So considering our present state of exacerbations, we prefer these SABAs and the SAMAs. But the LABA LAMAs, only it is said that if LABA patient was already on LABA, mostly it is for the maintenance therapy, which we give at home while discharging the patients. But sometimes we can always continue also with these treatments while the patient is already on a LABA, even in the exacerbation periods. That may help.
So very well said. And what to look out for also, you have said very clearly, look for tremors, tachycardia, arrhythmias, and look for acute urinary retention, which may occasionally occur. So coming to Dr. Dhaval, Preeti had already mentioned about corticosteroids in her talk, but we also come to, would you also give inhaled corticosteroids to all your patients in the nebulized form who come with a COPD exacerbation? And systemic steroids, what dose, any particular molecule is preferred or recommended?
Yes, ma'am. Basically, for the inhaled corticosteroid, if you think about the inhaled corticosteroid, we are not giving in each and every patient about the inhaled corticosteroids. Particularly, we are giving when the blood eosinophil count is high, or we can say it's a eosinophil guided therapy. We can start the inhaled corticosteroids as an alternative to the systemic corticosteroids. If we see about the systemic corticosteroids, then we usually preferred the methylprednisolone or prednisolone based on the cost and the patient's requirement. Like patient is not able to take orally or patient is in ICU, then we give IV corticosteroids, 40 milligram OD for at least, maximum for the 5 days, considering some side effects of the corticosteroid, short-term side effects like sugar fluctuation, blood pressure fluctuation, fluid retention, edema. Then the patient may have some psychiatric problems in like irritability and all. So we consider that, and we should not give more than 5 days about the systemic corticosteroids, because steroids helps in the improving the lung function as well as your oxygenation, the shorter time of the recovery as well as the hospitalization, and always decreasing the risk of further exacerbation as well as the treatment failure. So we always prefer the corticosteroids, systemic corticosteroids over the inhaled corticosteroids in the exacerbation of COPD patient.
Yeah, the duration, actually what is recommended is quite short duration.
5 days. 5 days.
5 days is what is recommended. That has to be guided by individual patient, but the standard recommendation is 5 days. So Preeti had also mentioned that in these patients, you don't want neuromuscular issues to develop because of giving steroids for a long period of time. That's one of the reasons you don't want to give it
longer time.
Coming to theophylline derivatives, Dr. Anand, any role in admitted patients? I mean, I know in the olden days, they used to give IV aminophylline for exacerbations of asthma and COPD. Do you recommend oral or IV preparations in any patients?
That's a very good question, actually. And we are all in practice to administer the theophylline derivatives, especially the derifylline when patient get admitted. But unfortunately, we can say that after the 2024, the guideline says there is no role of IV or the oral theophylline derivatives, especially those who are admitted. Not all. If we talk about the effect of derifylline, then we can say somehow it will be a good drug, may cause some kind of bronchodilation as an adjuvant therapy or add-on therapy, as well as some anti-inflammatory impact was also there. But the risk of the cardiac side effects is much more higher when we use this theophylline derivatives among the admitted patients. That's why it has been obsolete from the guidelines, and it is not recommended nowadays. After 2024 gold guidelines, we should not use idly the theophylline in the treatment protocol. Though we can use the steroid, that will be more safer if we feel that the patient have some inflammatory component like eosinophil count is more than 300 as discussed by Dr. Abhishek recently. We can add the steroid that is more safer than the theophylline. So we should ideally avoid, though not comment on the practice. Those who are doing it still, uh, maybe they may get some favorable results. So uh, probably the newer research will come up in the futures, and again there are chances it could be added, but at this point of time we can say we should not use.
Yeah. So I remember when I was doing residency many years ago, patients would come from outside and they would have all these side effects of IV aminophylline because there would be no regulation on how, and those calculations, side effects and all is something, of course, over time now it's not even recommended. And we are seeing that with all these other new molecules and with better OPD management of COPD, that at least when they come, it's more of an infective exacerbation rather than bronchospasm and other things that need to be addressed. So very well said. IV theophylline derivatives not recommended anymore. And oral also in very select group of patients and stable patients where, they very specific subgroup of patients, not to be given in all. Yeah. So Abhishek, discharge criteria from the ward in a patient who's had a recent COPD exacerbation. Any specific time duration that you would keep the patient in the hospital till the course of antibiotics is over? How do you decide that?
There is no specific time duration to keep the patient in hospital for a COPD. Some patient may get stabilized in a day or two. Some may take more times. Usually, patients, the first criteria is the patient should be clinically stable for last 24 hours to plan discharge, ma'am. The patient should be his inhalers or nebulizers should be, bronchodilators should be minimized to the maximum levels, where the patient's oxygen hypoxia is controlled. In hypercapnia, if it was there, that is well controlled in last 24 hours. And patient is now, if the patient was oxygen dependent, he is now to the best he was before getting admitted. Then patient is able to eat or sleep uh, without any frequent disturbance at night time, ma'am. He is able to do his daily activity, his routine activity. So that's this clinical parameter we should see. And most of our important clinical things which we have seen in our practice, ma'am, most of the COPD patients are senior citizen and they have a prostate enlargement. In this patient, before discharging them, we should try to get our urology people help to see whether BPH is there or that has been controlled, because often exacerbations are in the night time. When the patients repeatedly go for urine, do not get the proper sleeps, and they come to us next morning with breathing difficulties. For 2-3 days, they have not been able to sleep or not taking their medications. These clinical parameters we should see to make the patient discharge. And he was only support like vasopressors and all this has been stopped, then we should decide to discharge the patient with all the recommendations, whether if he's on oxygen, how to maintain his oxygen, how much should be the target with his LTOT, with if he is using pipette, he's using his NIV, how to use NIV. This should be well taught before getting discharged from the hospital, ma'am. This criteria also should be met before discharging a patient. And we should also take in confidence of senior citizens. Someone is there to take the care of the patient, because often we see patients are discharged in home. It's all two husband and wife are there, no children. They are walking outside. No one is there to take their care. Patient is not taking his nebulizer or inhaler regularly. They are not doing gargling after this bronchodilators. This all should be taken care. Otherwise, the patient will again land up within 2 to 3 days into to our ward or ICU with more exacerbations.
Correct. So very well, good points that you have brought out. A lot of patients on exertion, they develop breathlessness and come with exacerbation. So commonly, when they have BPH and they have straining at micturition, or sometimes when they're constipated, straining at stools. Yes. So these are the things that one should very clearly ask them and make sure that they are well controlled. The other thing sometimes is if you have a patient who is having issues at night, a lot of patients also have obstructive sleep apnea overlap with COPD. So that also should be sorted out, and Yes.
Cardiac, ma'am, this cardiac problem, this comorbidity should be controlled, ma'am, before discharging
Yes.
them. Comorbid
Yes.
conditions, ma'am.
Yes, absolutely. Preeti, would you like to enlighten us? We talked about nebulization during the hospital. Uh, when would you discharge your patient on home nebulization? Do you always aim that you have to convert them back to the inhaler that they were taking previously? Or it's okay to discharge them on home nebulization? Because the myth is that once you start on nebulization means you have to take it forever. Is that true? Or you can also de-escalate on follow-up?
Yeah, see, we saw that these patients have a lot of readmission rates, which lead to high mortality also. Almost 40% of them get readmitted within a month or 25% within 3 months. So here we need to look at these patients when we are discharging these patients. If we look at their peak inspiratory flow rates, which is very, very low, and it has been documented in many studies with these exacerbations. So what we look here is what is the patient status? What is their hand-to-eye coordination, whether they are able to take their device properly or not, if there is any kind of cognitive impairment which is hampering this process, what the device patient was previously using before coming to the hospital. We also have a set of kind of a nebulization score which we assess with the things in the mind, that there is a disease severity, there is a low peak inspiratory flow rate, there is a cognitive impairment, there is other comorbidities associated, there could be a lung carcinoma along with COPD, where in these conditions where the patient is not able to take the device properly, could not actuate or could not have that force to take the TPIs. So these are the set of the patients where we are sending them home on the home nebulization therapy, which is important because it is important that they take those drugs and they are being delivered adequately. So, but whenever they come for a follow-up, we always assess them. Again, we can do that nebulization score, which helps us also. If it is more than 20, we send them again on a nebulization therapy. But if they are improving, whatever factors we have talked about, if everything is improving, we always try to take them back, de-escalate them to the therapies, and also try to take them on an MDI with a spacer, which could be helpful to them, as most of them are elderly. So all these things we keep on trying for every visit, when they come for an early follow-up or a late follow-up, whenever we feel that they are suitable enough to, now they can handle their device properly. We can always check them in OPDs, which I usually do also, and ask them to bring the inhaler device also there, so that when we are confident that the patient is able to use the handheld device, obviously we shift them to the handheld device also.
Correct.
It is not that they keep
It's
on the
easier
nebulizer.
for them to take the nebulizers if they're agreeable, but then obviously they have their own issues about infection and most. There is a big long list of how you need to maintain your nebulizer
Yes.
when you're using it. It doesn't often happen in the wards also. You don't expect it to happen at home by the individual patient. So moving on, Dhaval, in type 2 respiratory failure of a COPD exacerbation, what is the preferred mode of therapy? First line of therapy would be non-invasive ventilation or invasive mechanical ventilation, and why?
So definitely, ma'am, when the patient present with the type 2 respiratory failure, the non-invasive ventilatory therapy is the evidence A therapy, and we should always give trial with the non-invasive ventilatory therapy unless it is contraindicated. So we know, as Dr. Preeti already mentioned, what are the indications for NIV in this, like particularly type 2 respiratory failure, because they can give benefit with the improves gas exchange. Then it always reduce the work of breathing as well as the use of accessory muscles. You always decrease the intubation rate, and particularly complication related to intubation, like hospital acquired ventilator associated pneumonia. Then the this airway defense mechanism can be lost. We need to give some sedations because patient is intubated. The hospital acquired other complications like drug related or maybe because of the ventilator related. So non-invasive ventilatory therapy always helpful in the improval of the, it studies also showing that it helps in the improval of the survival as well as the decrease the hospital stay as well as ICU stay and the further complications. So, and it is always a better tolerable for the particularly when the patient is COPD, and they can always communicate with the, when the patient is on NIV, communication, the feeding part, everything is easy when the patient is on NIV. But yes, meanwhile, we have to monitor closely when the patient is on NIV support, because when the patient is intubated, we get relaxed. But when the patient is on NIV, we have to be alert because patient can be deteriorated at any time. So always monitor after 1 or 2 hours of putting on NIV, whether the condition has improved, dyspnea has reduced, work of breathing has reduced, our parameters, heart rate, blood pressure, the carbon dioxide, oxygen level, everything has improved or not. We have to think about that. And when the patient is like failure of NIV, Dr. Agarwal has already mentioned, and Dr. Preeti has already mentioned what are the parameters when we can say the NIV is failed, then we can always think about the invasive ventilator support. And there are some contraindication as well, straight away contraindication about the NIV, like when the patient presented with the respiratory arrest, then we have to put directly on the invasive ventilatory support. When the patient is having severe hemodynamic instability, like severe arrhythmia or severe hypotension with the requirement of higher inotropic supports, patient is not able to protect his own airway, like the secretion and everything is not able to cough out properly, then the chances of aspiration is there. Then we need to put out the ventilator. When the patient is having facial trauma or burns, we can always go ahead with the invasive ventilatory support. Then patient is having persistent vomiting or aspirating, like in case of stroke patient, or when the patient is having some obstruction, upper airway obstruction, or when there is a recent surgery like airway surgery or upper GA surgery, then we can always think about the directly going for the invasive ventilator support rather than for the NIV support.
Yeah. If there is a facial trauma or there is bad burns where you cannot apply NIV in those conditions,
yes,
you may require to this thing. So moving on, you talked about failure of NIV. Again, coming back, I'm sorry, but I'm much older than you guys. When we were, NIV was still starting off to be used, and there was a very high conversion of NIV to invasive mechanical ventilation. And today now, with better modalities, better understanding, better mass, interface, we have lesser number of patients who are getting converted from NIV to invasive mechanical ventilation as failure of NIV, not for the ones who are a contraindication for NIV. So, Dr. Anand, initially it used to be said that ABG is a criteria that drives that, okay, this is a failure of NIV and we must switch over to invasive mechanical ventilation. Does that still hold true, or, now we have, it used to be said if the pH remains less than 7.2, then you should say that it's a failure of NIV and move to invasive mechanical ventilation. Do we still follow that, or we have changed our principles and we are a little more liberal in the ABG criteria?
Well, when we stick on the ABG criteria only, then the conditions are different. But when we talk about the practical experience, then it is entirely different. Since I'm working in ICU last 15 years, and I seen that when we talk about the PCO2 level, that is recommended more than 90, 92 mm of HG, that is an indication for the invasive ventilator. But as per my experience, I have seen cases when the PCO2 is more than 120 even, could be managed easily on NIV. And even if we talk about the pH, as you have discussed about the 7.25 and all, even lesser, even I have experience of the pH of 6.9 that has been bring out from that condition of CO2 narcosis by using the NIV. So that depends on the practical experience as well as the patient's conditions and whether he is able to tolerate that NIV or not, how chronic that disease is, because many times if the patient having the chronic COPD, the PCO2 level will be high, but the patient's condition will be seems as very comfortable or the normal. And I have seen few cases when the PCO2 level is 70 and they comfortably sit and without any exacerbation even, and it has been accidentally diagnosed as a case of type 2 respiratory failure. And we get panic in that circumstance that the patient have higher PCO2, why we should not put the patient on the ventilator. So we should keep patients, actually, if we are working in an ICU setup, we have to check the criteria other than the ABG criteria also. If the patient GC is poor, if the Glasgow Coma scale that is less than 10, or the patient's having some secretions which comes out from the trachea and patient not able to put that interface continuously. Along with that, if the patient have some comorbidities like CHF and all, and it's not feeling comfortable because of other comorbidities, then only we can think that we have to choose the invasive ventilator. Even many a times, if patient have some comorbidities and even drowsiness appear in an earlier stage of PCO2 or PH, we have to put the patient on the invasive ventilator, and that we can say it is a guideline that we have to follow. But the practical experience is also very important. Not only the ABG criterias that should be followed in a ladder and split in all the patients.
Correct. So I think two important points that you and Dhaval brought out is that once you put the patient on NIV, you have to monitor. So initial settings, you have put a patient on NIV standard protocol. You have to see whether you're generating adequate tidal volume. And then over an hour, you see whether the patient's respiratory rate has improved. Patient should not have become more drowsy. If patient is becoming more drowsy, obviously then irrespective of the ABG criteria, you have to then say that, okay, this is going to be a patient who's not going to be able to protect the airway and go to invasive mechanical ventilation. However, if the ABG is still bad, but the patient's respiratory rate has settled, work of breathing is settled, feeling less breathless, oxygenation is better maintained, then you can look at your settings of the NIV and see whether you are giving adequate tidal volume, whether you need to tweak the settings to improve your ABG.
I just want to add one more thing, Dr. Pratibha. Actually, when we talk about the high level of PCO2 and we get panic to put the patient on invasive ventilator, we have to see if patient is comfortable with the NIV. We have to check the ABG report after 2 or 3 hours. If the patient's condition get improved in terms of ABG or in terms of physiological parameters, we have to continue it because it will work.
Yeah,
that is actually a practical experience. If the patient get improved after 2 hours of putting on NIV, irrespective of that, whether PCO2 level is very high, like 130 and 140, there are few examples and case report where the PCO2 level is 200 and still the this BiPAP or non-invasive ventilator has used and comfortably went out and patient was saved without using the invasive ventilators.
Correct. So unless a patient is tuberose, you can still give an NIV. That's what we are talking about.
Definitely.
And it doesn't mean that we have to go by the ABG or CO2 or pH criteria. So Preeti, you had mentioned something about the settings that you would choose on non-invasive ventilation in a patient with type 2 respiratory failure. Traditionally, when we start with a pressure support that maintains a tidal volume of 7 to 10 ml per kg or higher. So in COPD patients now, would you still go with that thought process, or how would you decide your IPAP, stroke pressure support and PEEP settings?
No, nowadays we go with our lung protective strategies. That is, lung protective ventilation has to be given. So it's almost 6 to 8 ml per kg. That too, again, 6 ml per kg is the limit where we keep if the patient is generating adequate tidal volume of this per body weight. So here we see that once we start with IPAP, we give a pressure of, we can start with the kind of 8 centimeters of water of pressure, and we see if the patient is not able to generate tidal volume, we increase the pressure gradually by 2 in the monitoring the patient. The tidal volume has to be taken care of. So once the patient is not generating enough tidal volume, we still further go up to increasing the IPAP. We can go up to 20 IPAP, which will give us and also along with the PEEP. PEEP also has to be increased gradually by 111. Here we are looking at the oxygenation component, that what is the oxygenation of the patient, what is the SpO2 levels, while we are maintaining the PEEP levels also higher and higher. So with these settings, we'll decide that the IPAP pressures are going up, patient is generating adequate tidal volume, then we stay on those pressure supports, the settings. Also, along with that, we need to look at the other settings also. What is our trigger? The flow trigger is very important in these patients. What is the inspiratory flow set, which is again important. And the flow trigger should be around 2 liters per minute, which should be not be very sensitive, and it should not also auto trigger. So it is again important. Then another important thing is we have an expiratory trigger sensitivity also, which we seen on Hamilton ventilators when we give them NIVST modes, or we call it as a cycling, which should be set at around 40 to 50%, which for a normal person, we set it at 25%. That is cycling to expiration. So what here we are doing is we are decreasing our TI times. That is, the inspiratory time has to be decreased, and prolonging the expiration with I/E ratio, which has to be prolonged from 1:3 to 1:5. We are giving the time to the patient for good exhalation, and thereby improving the dynamics of the patient, which is important for the NIV settings here also. So this is how we gradually go step by step, increasing the APAP, looking at the tidal volumes generated, setting the EPAP, as well as the different ventilatory graphics, which we can see there also along in the NIV estimate also.
So when we start, initially we do start at lung protective strategies. However, there is recent data from the HAPPEN trial in 2024, which was an interesting study which spoke about low intensity versus high intensity NIV in COPD admissions with type 2 respiratory failure, and its effect on conversion to invasive mechanical ventilation. So when you talk about high intensity versus high intensity means you give tidal volumes of 10 to 15 ml per kg in patients who are not compensating their CO2. But of course, this is only you don't start it right away, but you can go up to that. As far as COPD patients are concerned, you spoke about PEEP. Usually, I think their PEEP requirement is not very high because oxygenation is not a problem. However, you have to compensate for the auto PEEP, as you have already very nicely mentioned. Patients who have an OSA overlap, in them sometimes you may need to increase the PEEP to higher levels to compensate for the OSA as well. So very well said, but do need to remember that if you have a patient whose CO2 is not settling, you can increase the tidal volume gradually and go higher as well. It doesn't mean that you should immediately, if the patient is conscious, tolerating NIV well, you immediately need to go to invasive mechanical ventilation. So coming to Abhishek, now patient has been on invasive mechanical ventilation and is fitting your criteria for extubation. Would you give post-extubation NIV to all patients, or how would you decide that? Because some patients may not compensate their CO2 completely. And then if you keep extending the invasive mechanical ventilation, they're at risk for developing hospital-acquired infection, ventilator-acquired infection. So at what point would you decide that, okay, I can try extubation and then maybe switch over to NIV?
First, we have to see the clinical parameters of the patients, whether the patient is conscious-oriented, whether the patient is able to protect his airway. That is the most important criteria before extubating any patient, whether it's a COPD or non-COPD. Then we have to see whether the patient's cough reflex is good, so that usually in COPD, the patient have viscous cough, which usually clog the airway and leads to difficult patient get intubated in ICU and prolong the patient's intubation time. Then again, we have to see whether the patient is able to have maintain his PCO2 in ABG, it is decreasing trend, and is maintaining FiO2 is lower in the with less than 40%, and maintaining his SpO2. Then we have to also see whether the rapid swallow breathing index is patient is less than 105. And we have to see whether the patient's vasopressor supports which were being used have been stopped, and the patient has good muscle strength. His GCS is improved. In that scenario, we can think about extubating the patients, and keeping in mind that patient may need repeat intubations. We should be very careful in using NIV or not using NIV in that patients, in COPD patients. Clinically, all patients do not need NIV post-extubation in a COPD patient, ma'am. The patients who are at the higher risk of having hypercapnia, or patients who are hypoxic, severe COPD background patients, or patients who have sleep apnea in association OSA with COPD overlap. In that category of patients, we should think about putting on NIV. And the patient muscle strength, whether most of the COPD patients are cachectic. In this patient, we should try to put NIV so that they do not again land up in ventilator, prevent reintubations. But if sometimes the patients have some good build patient who have landed up in ventilators due to some infections or this, and it is well controlled and the pose is controlled, they are extubated, they may not need NIV during post-extubation period, ma'am.
So somebody who has had an acute or chronic respiratory failure, those patients you may require to switch over to NIV post.
NIV.
post this thing. Also, obviously, your reason for intubation should have resolved. That is, whether it was a pneumonia, secretions, hemodynamic instability, or other organ failure, or sensorium. So these are the main 5 criteria which should have resolved. And patients should have been able to tolerate a pressure support trial at least, if not a spontaneous breathing trial, right? If the patient has tolerated a spontaneous breathing trial, as Preeti had mentioned, then you can extubate and not need NIV. But if the patient is not tolerating a spontaneous breathing trial, but is spontaneous pressure support well, and doesn't have too much secretions, has a good cough reflex, is not an hemodynamic parameters are good, X-ray has cleared out if there was a pneumonia, you could consider extubation and swapping over to a non-invasive ventilation. So coming to Dhaval, vaccinations are recommended for COPD patients to prevent recurrent infections. At what time would you give these vaccinations? At the time of discharge itself, or would you ask them to do it at a later date on follow-up?
Nice question, ma'am, because we usually forget about this vaccination when we discharging the patient. So we usually recommend during discharge only the vaccination. And we can have the particularly 2 vaccines we are considering. One is the pneumococcal as well as the another is the influenza. The pneumococcal vaccine is coming in the conjugated vaccine as well as the polysaccharide vaccine. And when we consider about that conjugated vaccine, about like PCV 2021, which are the newer FDA approved vaccines, we do not consider about the polysaccharide. Only one vaccine is enough, and every 5 years we can repeat this pneumococcal vaccine. If we have the PCV 13, then we always 13 or 15, then we always give the polysaccharide vaccine after 8 weeks or 1 year, 23. So this is regarding the pneumococcal vaccine. And the another is the influenza vaccine. We usually come across the various strain every year, changing strains, circulating strains. So we consider that influenza vaccine every yearly, and particularly in the September to October month, because before the starting of this influenza flu season, and particularly whether it is quadrivalent or tetravalent, based on the circulating strains. Particularly it's covering the influenza A, that is H1N1, the influenza H3N2, then and influenza B. So based on the circulating and the local circulating strain, we consider whether tetravalent or trivalent or quadrivalent we need to give about that vaccine. And particularly we need to consider when we give the vaccine, patient should not get the antiviral, or if we see whenever particular live vaccine, attenuated vaccine we are giving, then antiviral should be withdrawn, or if antiviral has been given, then we postpone the vaccination before 2 days of antiviral, and after 2 weeks after the antiviral treatment, particularly oseltamivir or zanamivir when the patient is taking. So live attenuated we have to taken care of when we are giving antiviral treatment.
Okay. So we also are giving the shingles vaccine now that it is available in
Yes.
Also the Tdap this vaccine that is recommended if it's more than
RSV
10 years. Yes.
And RSV.
Yes.
And
so Dr. Anand, there's a lot of talk about biologics in COPD, and is there any role of biologics in prevention of COPD? Is it available in India? What are the biologics, and when do we initiate the therapy? Is it to be given during admission for exacerbation, or it has to be in the stable state?
Yeah, when we talk about the biologics, it's actually a magical drug. Initially, it was used for bronchial asthma, but now the research will going towards the COPD management also, and one biologics that has been recently approved by the WHO and opted by the GOLD guidelines, that is dupilumab. That could be given even in a COPD patients, but there are some limitations. As you have asked, it could be given in admitted patients or during the exacerbation. So I say no, because in the acute exacerbation, it should not be given. Though after on discharge, when the patient gets stabilized, then we can recommend this biologics. But still, there are some constraints to give it in all the patients. There are certain criteria we have to follow. The patient have eosinophil count more than 300, then only we can recommend this dupilumab to them. Cost is another limiting factor for this biologics, because it is very costly drugs, though it is available in India, as you said. But the cost is a limiting factor, because it's costing around more than 50,000, 70 to 80,000 of the standard drug, which is available in the market. Sanofi, that is a company that has been launched in 2023, that has been approved here in India. So in after the 2023, it is available here, but the cost is always a limiting factor, which has been given twice weekly. So every fortnight it could be given to the patients with the as an add-on therapy with other therapeutic measures that could be given to the patients. So it will be effective. So it could reduce the exacerbation definitely more than 30% as per the studies which says. And there are a lot of trials, recent trials has been conducted on this dupilumab in COPD patients. And other biologics like mepolizumab and we can say lebrikizumab and tezepelumab, the research is going on, and we are not sure whether these biologics could be used in COPD or not. But still, there are a lot of trials which is going on, and these are also in pipeline. You will see in future, in few years, after few years, that a few more biologics could be added in the treatment part of this COPD. So we can say that this bronchial asthma and COPD become a single entity later. So we follow the Dutch hypothesis. So that could be proven later, because we are going in that direction where the pathophysiology of bronchial asthma and COPD will be the same, and it will be considered as genetically similar pathways, so that we can break it by using the biologics. Still, we can say the only one drug that can't be used in an admitted patient. Yes.
Yes. So eosinophilic phenotype of COPD, which is known to be responsible for recurrent exacerbations, is what this molecule is targeting. Of course, for those patients, there is also recommendation that you use a LABA/LAMA along with an inhaled corticosteroid first. And if you have a patient who's not improving despite standard therapy, then you would consider this drug, of course, with the cost limitation that is there.
Yeah.
So moving on, Abhishek, home non-invasive ventilator in COPD management. So recommendations on initiation and why, both Abhishek and Dr. Anand, if you would like to just chip into this question.
Ma'am, in home NIV, ma'am, the patients who are in hospitals who are on hypercapnia, or patient who have whose respiratory rate is higher on a respiratory, and the patient who are frequent exhibitors, in that patients we could recommend home NIV, and who used to get repeatedly admissions in serious citizens, or the patients whose lung capacity is too low, then we will recommend, especially overnight NIV is recommended. And the patients who have COPD OSA overlap, in that patients category patient also, home NIV is recommended. And the patients, they should be taught how to use the NIV, and how to clean the NIV at home. That should be maintained. Sterilization techniques should be well taught to them before advising them, so that it does not cause exacerbations, because NIV may become the source of acute exacerbation in the patient due to secondary infections. And again, the second part of your question was why? Because we have seen the patients, many patients of COPD who was used to retain CO2 come to us. If we can put them on NIV, the chances of getting CO2 retentions get less, and their exacerbations decreases.
Correct. So there is a trial which showed that patients who have recurrent admissions or of COPD exacerbations, and they come with type 2 respiratory failure initiation. The HOT HMV trial way back almost 10 years ago, which was the first path-breaking trial, which showed that it decreased prescribing NIV to these patients on domestic use, decreased their hospital admissions by 50%. And these patients also have a very high morbidity in the first 1 year after a discharge. So that's where...
Yeah, Dr. Pratibha, I just want to add one thing.
Yes, please.
In it. Actually, when we talk about initially the LTOT, long-term oxygen therapy, actually this long-term oxygen therapy has been replaced by nowadays in our Western areas with the long-term non-invasive ventilator therapy, because it has been seen that when we prescribe this LTOT, generally the patients have some basic level of PCO2 like 52, 53 and 55. It remains even after repeated admission. So in that circumstance, it has been perceived that if we use the home NIV, this PCO2 level could be decreased and the patient's lifestyle could be improved. Though a lot of meta-analysis has been conducted on it in 2022 also and in 2024, and that gives the idea about its prognosis. So the mortality rate will not be changed by using this home NIV, though the repeated admission in the hospital is drastically reduced. So we can change the lifestyle, we can improve the lifestyle of the patient, those who have been initially put on the long-term oxygen therapy and not been improved by it, could be switched on this long-term non-invasive home NIV.
You actually brought out a very good point, because recently there was a patient in the hospital who had two admissions with an exacerbation and was advised LTOT, and the third admission she actually came with type 2 respiratory failure. So the LTOT also unmasked, because sometimes they don't regulate the amount of O2 that they're using. Even if they require half liter, if they're using 2 liters, then that also can cause a blunting of the respiratory drive. So if you have patients with recurrent exacerbations, borderline CO2 or slightly elevated CO2, please do keep a watch out for their requirement for home NIV. Yes, Preeti, you wanted to say something?
Yeah, also in the patients who have cardiac comorbidities, again, NIV is really helpful in those patients, as well as those who have a lot of muscle weakness and the work of breathing is very high. Again, those set of patients are also candidates for our home NIV therapy.
Ma'am, and again, home NIV also used to prevent long-term COPD complications, ma'am. It used to decrease the cardiac pressures, which also helps in decreasing the chance of having PH and all other cardiac morbidities. Long-term, and again, the LTOT point which you have told, ma'am, during discharge, we should always teach patients how to maintain his SPO2, ma'am. They should be taught, the attendance should be taught, ma'am. That should be the criteria before discharging for LTOT. Otherwise, we should not prescribe, because it may be hazardous, ma'am. We have seen patients coming, maintaining oxygen 100% at home, coming to ICU with PCO2, but no one has taught them that they should maintain its 80 to 92. While going to washroom, how to increase the oxygen, how to use oxygen while taking bath or doing defecation, man. That should be, we should teach them how to work with oxygen, how to increase and how to decrease. That part should be during discharge, it should be mentioned to the patient, ma'am, nicely.
Yeah, I would like to share on this. I have a chronic patient of COPD whose relative knows each and everything about the SPO2. My nurse in the ward had been giving the oxygen levels, targeting an SPO2 of 100. The man is coming in front of me and telling it to the nurse, "Madam, inko itni oxygen nahi chahiye. Inko itni hi chahiye. Inko 88 hi bahut hai." So that is the way the patients understand with the long-term COPDs. The son knows each and everything about, and he knows that we have to maintain this much of oxygen levels.
Yeah. So not over oxygenating, great point. I think that it cannot be said enough number of times for COPD patients. Over oxygenation is a killer, which all of us at some point or the other in our hospital have been party to. So I have been informed that we have more than 1,250 logins for this webinar. That is very great. Thank you all the panelists. And we come to our last question, Preeti, which is for you in a continuation. So there are many newer modes of NIV available now on these portable machines, which we don't sometimes have on these other ventilators that we give to patients in the ICU. And when would you use these newer modes, which are AVAPs, IVAPs, and what are they?
So these are the newer intelligent modes which are used for the chronic hypercapnic respiratory failure, especially in the patients who are obese and also have OSA along. So these are the intelligent modes. They are giving a preset tidal volume is being delivered to these through these machines, and they are changing the pressure support system depending upon the patient's efforts. So we set an IPAP max and IPAP minimum in these settings. So we don't have to set a fixed kind of an IPAP, which we do for our NIV machines, which we have to go on assessing that whether the patient is comfortable, is generating that tidal volume or not. But here it is delivering that preset tidal volume and changing the pressure according to the patient's efforts through the flow loop or algorithms which have been provided inside the machine. So the patients will perceive it, normally they perceive it better and they have a better quality of sleep or while they are using these machines. IVAPs is also similar to AVAPs. It uses an intelligent algorithm and maintains an alveolar ventilation basically. So these are the smarter machines. They are looking at the patient's efforts, preventing a patient ventilator desynchrony, which happens sometimes while we have sent the patient home on a fixed IPAP and the patient has different problems with it and comes to us that the things are not being delivered and he's not comfortable with the machine. So these problems can be overcome by these smarter machines, which we can use these days, especially in the patients of obesity hyperventilation syndrome, where again, these machines are quite helpful, and in the neuro patients as well.
Yeah, so the overlap syndromes with COPD, OSA overlap. Now, the thing is, sometimes when you go on the ICU rounds, you see that, with your patient's tidal volume generation is very variable, especially when they're asleep, their tidal volumes are low. So you will see early morning PCO2 is high, daytime CO2 is good. So those are the kind of patients where after tweaking your routine NIV, if it is not helping, then these kind of settings will help in getting their CO2 streamlined, and you don't have to keep a hawk's eye on tidal volumes because you have an option of keeping a limit of pressure and the tidal volume is automatically delivered, as Preeti said.
Nowadays, they also have an auto EPAP.
Auto EPAP version, yes.
EPAP
yes.
max and EPAP minimum can also be set in. So,
in fact, some of these machines are much more useful than our invasive ventilators for giving.
Yes.
So we have a couple of questions in the chat box. Somebody is asking, what is pneumothorax? So anybody would like to take that question and how is it relevant to this discussion? Anybody?
So our audience are residents also.
Yes.
They must know about the pneumothorax, and if but they actually ask, what is pneumothorax or what is the management of pneumothorax in ICU? What is exact question?
It just says, what is pneumothorax?
Pneumothorax is a condition, if we radiologically say, then if there is an air which entered in the pleural space and it separates the lung from the chest wall, then it could be said as pneumothorax. So if collection of air in the pleural space, that will be a condition that is known as pneumothorax. It could be closed type, it could be open type, that you can refer from the books. So the management will be decided on the type of the pneumothorax. First you understand what is pneumothorax, then type of pneumothorax, and then the management plan will be planned accordingly.
Yeah. So in this context, I think this question was asked when Abhishek had put up a slide saying that one of the differentials or complications is pneumothorax. So when you have cyst formation in the lungs or you have excessive hyperinflation in the lungs, then those can be predisposed to a leak of air and development of pneumothorax, as Dr. Anand said. And your management will depend upon the severity and the underlying lung disease. So there is another question here which I'm not completely able to understand from Dr. Anil.
COPD with PH, ma'am. I think sir is telling.
COPD with PH, right?
PH. Yeah, sir want to tell COPD with PH.
Yes. So, I mean, I think we've already covered that aspect of it. So, LTOT is what you would recommend. You will also look at for patients predisposed to CO2 retention and manage. We've covered that question. Another question from Dr. Sandeep is, when will I refer the patient to hospital when patient's oxygen saturation is below 80%, 82%? You would definitely send this patient to the hospital and avoid managing in your clinic, because we have already discussed ad nauseum that you don't want to give high flow O2 to a COPD patient who has a low saturation. You would want to do an EBG, see whether the patient is requiring an NIV or not. So this patient would be preferably better managed in the hospital, especially if his otherwise baseline saturation is above 90%. So that is what you would do with this patient. We have a couple of comments from Dr. Tridip, who says that do look for COPD with bronchiectasis, especially if the patient is having a lot of cough, and then do a sputum and definitely look for Pseudomonas in the sputum. Good point. And again, checking NT-proBNP is commonly done in routine practice, which we have already discussed, because we do want to rule out a concomitant heart failure. So that was a great discussion, great questions, great presentations.
I just want to add the one thing related to the pneumothorax has been asked and relevant to this topic. So whenever patient present with the COPD exacerbation, we always treat the comorbidities as well as the mimics as well. So sometimes two disease can present together. So one is a pneumothorax as well as some other cardiac and all.
And it could just be a complication of a severe COPD as well.
Yes, ma'am.
So everybody, just a couple of lines to summarize your thoughts and your takeaway messages on COPD in hospital management ward to ICU. We can start with Dhaval.
Yes, ma'am. Nowadays, because of the COPD, we know the COPD is a large burden nowadays, and the repeated exacerbation are coming with the whether it is infective, non-infective cause. So if we judiciously treat and on the discharge, we take care of about the maintenance part, then we can always reduce the readmission as well as the re-exacerbation.
Yes, Dr. Anand.
Yeah, definitely. My take-home message to all is that we have to make the perfect diagnosis of the patient before admitting them either in a ward in an ICU. So try is very important. Use rationally, judiciously the appliances, not in hurry, that because they have some own complications, because we have to choose NIV or invasive mechanical ventilators rationally. Along with that, we don't hurry in weaning. We have to check all the parameters before going towards in that direction, whether the patient's condition get improved or not. As well as when we send back to the patient to their home, we have to check whether he's trained for that particular treatment or not, or the rehabilitation program has been set for that particular patient, so that we can give the holistic treatment to them.
Yes, Abhishek.
From the whole discussion, we could make out that oxygen is the soul of entire discussion. So whenever COPD patient discharged, or I tell to my team that patient has come for oxygen, whether due to low oxygen and he's fighting for oxygen. So underuse or overuse of oxygen may be dangerous for the patient. So be careful, one thing. And also about the inhaler and the nebulizers, we should be very careful taking the choice of, and while discharge, the patients should be counseled about using it regularly. Without most of the time we see patients stop deaths after getting well. And third part is, ma'am, how to prevent, exacerbations. Especially, I always ask my patient to wear mask whenever they're in the public place, or where in the home if they are doing some dusting or cleaning. These 3 points, if we can maintain, ma'am, most of the patients' exacerbations can be prevented in COPD, ma'am. While public place, a mask use is a must, ma'am, for the COPD patients.
Good points. Yes, Preeti.
Yeah, now we know that these exacerbations are associated with very high morbidity and mortality. So we need to look them, we need to diagnose them properly, treat them. And while we are doing all this, I think a psychosocial support to the patient is also very important, and educative programs to just tell them about the disease, the process, and what all they're going to suffer, or whatever they can do to prevent it. Of course, as Dr. Abhishek said, has to be educated to the family as well as to the patient, which is again very, very important. And we lay stress on the parameters as well as the SpO2 levels, which we had been talking about in the last 1 hour. Do not over oxygenate these patients. And just prevention is again very important. The vaccination, role of vaccinations, the smoking cessation, and pulmonary rehabilitation, which we haven't talked about much, is again a very important program which can be linked with these after moderate to severe exacerbations. They have to undergo these chest physiotherapy cycles with aerobic strength exercises, which will gain them the strength. And we have to counsel them again and again about this. on our follow-ups.
Yeah. So my pet peeve with most ICUs is that they don't understand COPD very well. They don't take history. They start oxygenation, higher oxygenation early. They're not even very familiar with all these newer modalities of non-invasive ventilators. So I think we should all collectively enlighten our colleagues, enlightening our other internal medicine and ICU colleagues about all these things so that we can treat these patients better. And one common thing that we face in practice is, patients will say, oh, if you've decided that the patient needs an NIV machine at home, they'll say, doctor, it's expensive. So you need to counsel them and tell them that each ICU admission is 20 times more expensive for you. So I think that is how we should probably, and unless you're convinced yourself, you cannot convince your own patient. So I think that is why these kind of webinars are important to spread the information. I thank CCI, thank Dr. Krishna, Dr. Vijay for continuously coming up with these ideas for these webinars, the CCI Executive Committee, and our academic partner, Mankind, for their support. And of course, all our lovely panelists today, Dr. Dhaval, Dr. Anand, Dr. Abhishek, and Dr. Preeti. Thank you very much and good night.
Thank you, Dr. Pratibha, for excellent moderation.
Thank you, ma'am. Thank you.
Thanks, ma'am.
Thank you, everybody.
Thank you, CCI.
Good night, everybody.
Thanks, everyone. Good night.